this is what. Okay, so I just heard the recording in progress. Okay, that's fine. So let's look into another next slide. So, the next one, please. So we also say that, again, we need to be sensitive to how our communities, live together, in terms of the family dynamic, in terms of intergenerational setting, and all of that is not just, so simple by, translating from English to the language you have. So we really would like to also say that we don't see a lot of representation taking into account of the religions and also the cultural setting. Next one. So take a look at this one, if you will. I don't need to say more. So what do you see are the issues, right? Even though I don't speak, Arabic, but you can see that, definitely this picture, the images is not correct. So next one. At this time, I would like to ask Shogofa. Shogofa, can you mute your mic? And then maybe you can talk about that. That is, to her, down particular language that she pointed out to us. Shogofa?
Yeah. There is some grammatically miscorrect translation about this. It's in the real language, the official language of Afghanistan. So it doesn't, in here, as you see the red circle, it doesn't mean any sense. So maybe they use the Google Translator. The Google Translator just translates word by word, but when it translates to other languages like Dari or Pashto, then it doesn't make any sense. Thank you.
And also the link. So you want to talk about the link?
Yes, also they just put the link in here, but instead of that, they wrote about that, like you can go to this, and they explained about that, but it doesn't make any sense for those people who doesn't understand how to use it. So if they could just put the link in here, so it would be good.
Okay, thank you. So let's go to the next slide in interest of time. The next slide, Shogofa. So again, to see that it is, from her culture as well. You can see it says a flyer being translated. It doesn't accurately really represent, our, Afghan, cultures, right? So also the distancing measure in terms of, feet, and it is something that they might not necessarily be able to relate to right away. Next one. So as a project, what we're trying to say is that to address, the COVID information, to help, really alleviate some of this mental stress, we really want to take a look information that's given, information that is, developed, and also look at taking into the cultural perspective, which is so important. So lifting all voices is really from that standpoint of how can we reach out to give information to all community in a culturally relevant and linguistic, appropriate manner. Next one. So we have some recommendations. This is really listed on the screen in here. Basically, again, using proper translation, using cultural guidance from leadership, and using your community-based connection, and help help the providers, help communities connect with each other. Next one. So we want to see that focusing again, being personable, being relevant, being supportive, so that communities can use the information themselves, be able to make informed decision, taking the test, being vaccinated. So all that is, you don't have enough information, it is very scary. So from that perspective, again, we are not mental health providers. We just want to look at how can we help to reduce the mental health stress for our communities. And this is very important because it is kind of timing wise. The COVID-19 started around in 2019. Around December, we having seen a spike, and then in December 2020, in the year 2021, last year, right around in August, to be exact, August 15, I think that is a Taliban insurgent. And I want to take the next slide to show you, that that's how the community to respond, to the needs of the community. with this insertion, we come to a lot of refugees. So right now we're over 100,000. In Frederick, in Maryland, down, we have in Frederick over 100 with settled down family. And we want to tell you the story from her insight is Poana, and Poana is one of those who came to Frederick. This is a beautiful, this is where our office is, so you can see that we have a beautiful downtown Frederick. They felt isolated. They have, particularly those who are so new to our country that, and then in this particular time of COVID, what can we do? So information must be given, delivered, shared in a culturally relevant manner. And what's the best way to do but to use the people themselves? Next one. Next slide. So I want to share with you how we help. When Puanas come, landed really, in the United States and came to Frederick, we're able to hire her. So I think it's very important for those of you who work for the immigrant community to understand we lift up our community by really building self-sufficiency and independence. And this COVID-19 really makes it so hard for those who've been here for a long time and those who also come, most recently. So any way that we can do, looking at resources, information, but the best thing is to provide them, an opportunity so they can serve. So it's very fortunate that Juana's English is pretty good, so that she understands, the professionally, so that we bring her in as a community health workers. And I know that, all this conversation I have since the beginning of my presentation, I have one thing I want to share with you, which is really the needs of community health workers. Bilingual, bicultural community health workers is a way to address our mental health needs for our communities. Next one, so she is, well trusted. She began to know her communities. She went to the mosque and she really helping others. The new refugees will come to our communities as well. So I want to emphasize that this information we know now to have some issue in translation, in terms of design, in terms of delivery, in terms of the content. Yet we can solve this by having community members such as Poana to work with us, train them to understand the public health system in the United States, but combining her expertise with language and cultures, then we can certainly improve the mental health, stress of our communities. So with that said, next one. So again, go back one more, go back to that. Go back one slide. Okay, so we have 5 more minutes. Thank you. So what I'm saying is that in trauma and also other crises, community plays a very important role in good mental health. So developing, them, helping them to understand. As an immigrant community, I can share with you that one of the most difficult tasks is really increasing the capacity of our communities. So we have to start where they are. So training them, but we have to be respectful because they know more than we do, from where they came from. So combining their expertise and also our professional, expertise, we make a better partner to serve our communities, in this case, our Muslim community. So I found that Poana actually lift up her voices and embracing awareness and concerning trauma and mental health in her community. So I hope that you can see how important information are. We show you that what we have learned from our analysis, we also come up with solution to you that uplift our community by embracing the cultures, by helping and lifting up and training them. So at this point, I want to thank all of these our partners, as you can see, but I want to already point out and thanks so much to Dr. Cindy Bao. She is the director for the health literacy, Harvard School of Health Literacy in University of Maryland, our evaluator, and my staff. Look at my staff, this is only a portion of them. You can see the different last name, you can see Korean, you can see, and our different languages, Spanish and Chinese and so forth, Farsi, Dari, and Gujarati, so all of that. So with that said, I thank all of you for your attention and also for this opportunity for us to advocate the importance of cultural relevant and language specific services, to our community and how we can reduce the mental health stress and then really lifting them up. And then hopefully we have a good recovery from this terrible pandemic that we endure. So thank you so much. And this is, the funding sources that we we have to present this information to you. I welcome your questions and if you have any. Thank you also, the screen named here, Shogofa. Thank you. And thank you so much to our moderator.
Thank you very much, Ms. Chung. Just so you'll know, this is a hybrid conference, so there are people who are on the Zoom, participants on the Zoom, but there's also participants in the audience, which you can't see right now, but they also appreciate your presentation.
I did not know that, but thank you.
Oh, yes, it's hybrid, so we have some.
We're very honored.
Say hi, everyone. Just say hi. They can hear you.
I think it's really great. I think that this is a great asset. From my standpoint, community assets is so invaluable. So we want to thank you for this opportunity today to share with you.
Thank you, and we hope to have you continue to share with us as well.
So we will have the question and answers at the end. So for now, I wanted to double check, is Miss Amna Bibi is here?
Presenter Amna Bibi. Okay, well, if you have any questions, whether you're on Zoom or you are in the audience, please write them down and we will get them from you at the end. And if you're in Zoom, you can put it in the chat directly to the moderator, the host moderator, myself, Sana, or Eamon, and we will get to those at the end. And we will go on to our next presenter, Ms. Hafiza Ufra, Alauddin. I'm going to just share my screen and then you can, are you with us? Great.
Yes.
Thank you. One moment while we get your screen up.
Can I start?
One moment. Let's just put your presentation up and then.
Okay.
So can everybody see our screen?
Yes. Can I start?
One moment. So we're going to introduce you.
Okay, thank you.
Yep. So our next speaker is Ms. Hafiza Ufra Alauddin. She has a master's in applied psychology, and she currently works at the Institute of Applied Psychology at the University of Punjab in Lahore, Pakistan. Her presentation today will be on the well-being in lockdown, the role of Muslim religiosity to overcome the coronavirus anxiety in Pakistan. Thank you, Ms. Alauddin, you may begin.
Okay. Assalamu alaikum. A warm welcome to everyone. I'm very pleased to achieve this opportunity to describe my title in this platform. And my title name is Wellbeing in Lockdown, Role of Muslim Religiosity to Overcome the Coronavirus Anxiety in Pakistan. And my presenter name is Hafiza Alauddin and co-author is Dr. Afifa Anjum, Assistant Professor, Dr. Anjum, Assistant Professor, and Dr. Rafia Rafiq,
Director Professor of Institute of Applied Psychology, University of Punjab, Lahore, Pakistan. And basically, this is my designation of MSc. Next slide, please. Next slide. Can you listen me?
Yes.
Can you see the slides moving?
No.
How come? Stop sharing and then.
Now,
How about now?
previous slide, please. Yes, thank you so much. Now formally start with description of my construct. First of all, my first construct is coronavirus anxiety. Now I explain what is mean in my study, what is coronavirus anxiety. Coronavirus anxiety is negative emotions that identify by anxiety, distress, abusive thoughts, and physical changes due to the challenges of psychosocial factor, according to Sherman 2020. Quarantine and lockdown during coronavirus developed enormous challenges and problems for psychological health. People use various coping strategies to overcome their fear, anxiety, and stress that arise due to social isolation. Positive religious coping is one of them that appear to be in a great alliance with mental health and emphasize on religious spiritual coping strategies that overcome anxiety and distress and help to maintain their well-being, according to Young 2018. Next slide, please. Thank you. Religiosity includes two dimensions according to Miller et al. First, it consists on abstract cognitive, and second is religious positive concrete participation in religious institutions. So according to Friedman 2011, religious coping describes different ways in which people understand and deal with negative life events that are related to scared situations. And inner satisfaction with involvement and religious practice is included in their participation with religious institutions that consist on practical practice. Inner satisfaction involvement with religious practice is the calm, peace, tranquility, and satisfaction inside the person. It is not physical, but an emotional satisfied state that achieved through religious practice. According to Brasser, it includes fasts, prayers, and etc. in Muslim religiosity countries. Next slide, please. As per Reef, psychological well-being is not a just matter of freedom from psychological distress and absence of disease. However, consists of self-actualization, self-fulfillment, healthy interpersonal relationships, sense of accomplishment, independence, meaningful existence, and motivation for continued growth. Next slide. Basically, all previous are my construct. Now I explain my theoretical background that explain how my study work supported through empirical ground. First of all, my construct were supported by cognitive behavior paradigm that explain how coronavirus anxiety occurs, that our thoughts influence our emotions, and emotions can influence our behavior that lead to our unconscious cognitions as well as unconscious maladaptive behavior. And brief recap, pigment theory explained that when we are in negative situations, we attract two different coping strategies that may be consist on positive versus negative coping strategies. And positive coping strategies like include comfort by wishes, closeness to God, invent as God will, and negative include making doubt about God love, care, illness, and punishment have influenced our mental health. Next slide. Now, It explained my hypothetical models. My model explained that coronavirus anxiety attract the individual towards coping. Coping include different strategies. Now I explain the religious coping strategies that consist of positive versus negative part. Positive explain that it helps to high our inner satisfaction that promote our well-being. Toward negative, it destroy our well-being and create dissatisfaction toward situation. Next slides. Now, objective my study. The main objective of my study is to investigate the association between coronavirus anxiety, religiosity, and psychological well-being in Muslim adults, and also to investigate the coronavirus anxiety, religiosity as a main predictor of psychological well-being while controlling for demographic variable in adults. And last but not least, to investigate any differences occur in study variable on the basis of their demographics. Next slides. Now, my hypothesis. My hypothesis is that religiosity may be likely to be a significant predictor of psychological well-being and correlate with positive coping, inner satisfaction with religious practice, and positively correlate with psychological well-being, while coronavirus anxiety is likely to be significant, positively correlate with religious negative coping, while negatively correlate with religious positive coping. Next slides. Religious positive coping, inner satisfaction with religious practice is likely to be a significant positive predictor of psychological well-being after controlling for demographic variable. On the other hand, coronavirus anxiety and religious negative coping is likely to be a significant negative predictor of psychological well-being after controlling the demographic variable. Last but not least, there are likely to be a significant differences in coronavirus anxiety, religious coping, inner satisfaction with religious practice, and psychological well-being based on demographic variables. Next slides. Now I explain my method and research chapter. Methodology explains that we conduct research on quantitative base. Quantitative research design were used and to recruit the sample for passive sampling strategy were used. And 135 Muslim adults were recruited to collect the data that age range consists on 18 to 15. And individuals with severe medical condition and severe psychotic elements were excluded that may be a confounding variables for our study. Next slide. Assessment measures. Coronavirus anxiety scale Sherman 2020 were used to measure anxiety level that explain greater than 9 score indicate problematic symptoms. Inner satisfaction with religious practice scale were a self-constructed scale that developed by my co-author Afifa Anjum and her student Bashir 2018. It was basically constructed to measure inner satisfaction in our country that involvement to connect it with obligatory religious practice. Brief religious coping scale, Brickman scale were measured to find coping strategies of religious that consist of two scale, positive versus negative scale. Psychological well-being scale, popular with as we know, that depend on 6 subscale scale were measured to their psychological well-being on different domains of their life. Next slide. Procedure. Pilot testing were started on 30 participants. Due to the outbreak of COVID-19, all questionnaires were administered through Google Forms. It is based on website study. Data collection was initiated on 20th October 2020, and statistical analysis SPSS Vision 23 were used for analysis of result. Next slides. Results. Result of my study considered the demographic age were positively correlate with coronavirus anxiety, while my study explained negatively correlate with religious negative coping. So religious positive coping, inner satisfaction with religious practice and psychological well-being positively correlate with each other, while negatively correlate with coronavirus anxiety and religious negative coping. Coronavirus anxiety and religious negative coping positively correlate with each other. Next slide. Demographic variable were controlled except gender. All demographic were not predictor of psychological well-being, while gender positively predicts psychological well-being. As far as gender is concerned, being male predict more psychological well-being than women. Further, in main study variable, religious positive coping, inner satisfaction with religious practice, positively predictor of psychological well-being, while coronavirus anxiety, religious negative coping strategies were negatively predictor over psychological well-being. And overall model explained 20% variance and 20% predict all my study variables to my psychological well-being construct. Next slide. Study also investigate the differences with respect to gender, work status, and track versus indirect exposure respectively. Men use more religious positive coping and develop psychological well-being, while women use negative coping and develop lower level of psychological well-being. Job professions had more coronavirus anxiety, and my study explained use more religious positive coping, while students use negative religious coping and had lower level of psychological well-being. When we investigate track versus intract exposure, and research shows track exposure individuals that exposure to their families and relatives had more coronavirus anxiety in comparison to intract exposure people who exposure mass media. And those who have track exposure use more religious positive coping and attract to more religiosity than those who have indirect exposure. Indirect exposure people use negative coping like smoking, alcoholism, and other things that may have lower level of psychological being in comparison to track exposure individuals. Next slide. Study also investigate the variance with respect to 5 income categories, 3 quarantine categories, and different 3 virus recovery categories. Differences observed in religious positive coping and psychological well-being between 2 income categories and post hoc indicate individuals who have higher income level more than lack use more positive religious and reported higher level of psychological well-being rather than who have lower level of income, and other groups were non-significant differences. Post hoc tests also indicate that hospital quarantine people had more inner satisfaction because they use religious practice than not needing quarantine people in comparison. Other 2 groups not needing quarantine or home quarantine people had non-mean differences. Last but not least, post hoc indicate that people recover from viruses had more inner satisfaction through their religious practice in comparison to virus-free people. Other 2 virus-free and non-recover people had non-mean differences. Next slide. Conclusion of my study. The finding of my study revealed positive association through religious coping, inner satisfaction with religious practice, like involvement in our religiosity, have developed psychological well-being, while on the other hand, negative association between coronavirus anxiety developed affect our psychological well-being. Study revealed that positive religious coping reduce and help to maintain our mental health, while negative coping affect and psychological distress were occur. COVID-19 pandemic caused psychological distress due to fear of spreading virus, lockdown, isolation, lack of social support. However, individuals using positive religious coping and having religious involvement succeed to maintaining their mental health. while individuals who use negative coping stress, anxiety, and depressions. These studies enhance our understanding of how religiosity and positive coping strategies help us to reduce psychological issues while providing residents support and courage to face uncertainty of life. And these present studies conclude to be coherent with other many previous studies. Next slide. Limitation of my study. The COVID-19 situation was changing in severity level, and that's why anxiety level were fluctuate and influence my appropriate and proper information about COVID-19 anxiety scale. Subjective self-reported measures were employed via online form. So study collect data through internet from educated people, only which resist access to those people who do not use internet and not highly educated. Next slide. Implication of my study. My study finding of this study may be utilized to develop strength-based therapies, intervention of religious coping, and religious practice that can be beneficial for increasing well-being in Pakistan Muslim adults. Such steps should be taken from grounded level that make encourage strength and resilience among individuals in different circumstances to maintain their well-being. For example, if we start these activities from school and initial mass community center levels, so it is a grounded level, we can become aware of importance of religiosity and pandemic situations, spirituality in our life that become able to maintain our well-being in these type of pandemic situation and other uncertain situation. Next slide. And thank you so much. This is all from my side, and I am grateful to achieve this opportunity. Thank you so much.
Thank you, Ms. Alauddin.
Thank you.
Is Ms. Amna Bibi, our next presenter, Amna Bibi, are you here? If you are, can you please unmute yourself? I have a couple. Someone asked about the CME. So there's instructions for getting the continuing medical education credit, CME, within the Whova app. And you can find that on the Whova app itself or ask one of the organizers in the Ask Organizers tab. Actually, I'll share that really quickly. So if anyone who's interested in the CME credits, I have the code here. I'll just share the screen quickly. So this is the event code. Also, if you in the audience want CME credits, you can also do this right now too. The event code, and if you're US Canadian learners, this is what your options for completing it and getting continuing medical education credits. So we did have one more presentation, but unfortunately the presenter is not here for that one. It was the depression and post-traumatic stress disorder in corona-affected families by Miss Bibi, and she's not here. So if anyone has any questions, we could do that at this time. And for those of you joining us now or a little bit later, my name is Sana. I'm a moderator and I have a co-moderator, Eamon. We are doing a hybrid conference. We have some people in the audience here and those of you on Zoom. The presentations will be recorded and available after the conference on the Muslim Mental Health YouTube channel. Anyone have any questions in the chat, or it can be for any of the anybody not have questions but have comments? No? Yeah, sure.
So for the second presenter, there was some kind of demographic information that seemed to show differences in the results. And I was especially curious about the difference between the job professionals and the students. And I was wondering if the speaker had some information about why it was that job professionals were more likely to use positive coping skills and students were more likely to use negative.
That's a really good question. So that was for Miss Alauddin. So let me go back to Miss Alauddin, Miss Hafiza for Alauddin. We have a question from the audience.
Yes, yes, I'm here.
1 second. We're having a little bit of technical issues on our side, sharing our screen with our audience. But those of you who are on Zoom, you can hear me correct and see me correct. Yes, anyone? Well, in the meantime, you want to ask your question?
Sure.
I actually, yeah, let me. Here, how about I give her this paper? Ms. Hafiza Ufra, we have a question from the audience for you.
Yes,
Do you remember my question?
It was a good question, but not
Oh,
exactly.
it's just the difference between the job professionals and the students and their
Okay.
coping skills that they use.
So, Ms. Alauddin, the question that we have from the audience is, in your presentation, you talked about the difference in coping skills between job professionals and students. And the question is, what factors?
Yeah, does she have any information about why there is a difference?
Yeah, do you have any, from your research, or do you have any inclination of the difference of why there are the differences in coping mechanism or coping positivity or negativity between job professionals and students? Did I ask your question? Okay. Ms. Alauddin? I don't know if you're speaking, could you please unmute yourself?
yes, I have research that explain that job professions individuals have more experience during life in comparison to students who have in adult age. Due to their adolescent age, they have less experience and less known about the coping strategies that they affect on their health. So job professions therefore use more positive coping strategies that have help on their well-being. Right. On the other hand, to those students who have student level and not knowledge about rather than coping strategies that might be influencing their health. So that's why they use their group level strategies that include maybe alcoholism, smoking, and negative strategies like denial.
Okay, so it sounds like what you're saying is it's because of the maturity level of coping skills between more like maybe not necessarily job or maybe it is also job, but yeah, the maturity level from between the job aged people and the student aged research.
Yeah, your people have more words.
Thank you so much, Ms. Alauddin. Does that answer your question?
And sorry about the screen. I'm trying to do everything.